Good afternoon, everybody, and welcome to our town hall today for Friday, May 15th, 2020. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs at Hamilton Health Sciences, and pleased to be with you today, joined by a number of colleagues to give updates on all things that are happening across our hospital related to COVID and as well related to other initiatives. And we'll have an opportunity for questions today. I guess as a matter of housekeeping, when we get to those points in our agenda, you can use the chat function to ask a question. You can also raise your hand in the participants list, and we'll do our best to get to as many of those as we can. So without further ado, I'll ask our President and CEO, Rob McIsaac, to kick things off today. So Rob, over to you.
Okay, thanks very much, Aaron, and welcome, and thanks to all of you for joining our first official staff and physician town hall. I know how busy everybody is, so I appreciate you making time for this in your schedule. As our organization continues to navigate through this very challenging time, we felt it important to create a regular touch point to keep you updated on key issues and initiatives, including, of course, our response to the COVID pandemic. This is something we intend to continue on a regular basis, so I hope you'll tune in whenever you can and take the opportunity to ask questions of our leadership team. We are here to provide as much insight as we can. Let me begin by saying thank you to all of you for your remarkable hard work and personal dedication to the mission of our hospital during the last 3 months. I know your commitment is always present, but I think everybody at HHS has really risen to the challenge of this pandemic. I also know that the personal toll waged by this extraordinary time is also very challenging. You have families and your own well-being to look after and to worry about, while at the same time you're continuing to do what's needed to keep our hospital functioning safely. So your dedication to HHS and the patients we serve is very much appreciated. Thank you. I think we have a lot to be proud of in terms of how we're serving our community and our province. The pandemic is far from over, and it will no doubt continue to impact on our lives personally and professionally for many months to come, unfortunately. But at the same time, we are shifting our focus towards a new normal. Planning is happening now for the gradual reintegration of clinical services, and some of the projects that were paused during our initial pandemic response, we're now starting to think about again. Dr. Wes Steven is here today. He'll provide more insight into the process of ramping back up. At the same time, as I mentioned, we are also starting to resume efforts on some of the critical transformational projects that were underway prior to the pandemic. This includes projects in our digital health plan, as well as the selection process for a new health information system for HHS. It also includes important projects for the redevelopment of our facilities and the renewal of our equipment fleet. I'm happy to share some transformation updates with you today. We are going to leave time at the end of each presentation for some questions and answers. We'll have limited time, but we'll do our best to accommodate as many as possible within the time that we have. So I would just encourage you to engage if there's something you're wondering about. We'll also pause at the end of the meeting to have a moment to call out any celebrations. So please consider that and be prepared to contribute if you have something or somebody that you'd like to recognize. So at this point, I'll invite our EVP, Clinical Operations and Chief Operating Officer, Dr. Wes Steven, to take over the presenting role, so he can give us an update on some of our our service reintegration planning. Again, my thanks to all of you for your tireless efforts and commitment to HHS and for being part of today's discussion. Wes, over to you.
Oh, Wes, you're on mute.
Thank you, Rob. I think it's fair to say that a health crisis that we're experiencing has been like no other. I'd like to echo Rob's comments about a huge thank you for your dedication. It is clear that we are living in a very uncertain or ambiguous time for ourselves personally and professionally. And to acknowledge that each day our workers come to Hamilton Health Sciences with the obvious questions, how do I keep my patients safe? How do I keep myself safe? And how do I keep my family safe? And despite all that, the amount of work, the quality of work that has been performed by our organization is simply amazing. And that's a huge thank you to our people and all the collective work that's been done in the last several months. However, our work continues. Rob did highlight that we need to start to reintegrate the services that have been paused. There are some key elements to our planning, and it's important to state that this is going to be an initial phase or initial reintegration of the paused work. And really, the four main components of this work is really around capacity and data and modeling. Another is around a ethical framework with clear principles of our task forces that are looking at ambulatory, DI, intervention, surgery, and an engagement of our frontline workers, our leaders, our patients with patient advisory, with our university partners, our medical advisory committee, to get input on the process and on the content of the clinical services that have been paused. And we need to coordinate this in a way that is planned, period. So next slide, please. I do want to spend a couple seconds really just talking about some concepts that we believe to be true, although not totally proven. And so it appears our initial experience in the world with respect to COVID-19 is that it probably is spreading easier than influenza. As a result of that, that means that more people will need to be infected before the herd immunity or our community is immune before the pandemic can end. The implication of that is that it will take us a longer period of time to actually come out of this phase of having COVID in our community. Why we believe that the COVID is spreading more easily is that it appears that we've not had any immunity to this virus before, that cross-reactivity to other coronaviruses doesn't appear to be occurring, that the pre-symptomatic state is longer, and a lot more people get COVID and have mild disease and are not aware that they're carrying it and spreading it. So the current thinking is that we need 60 to 70% of the population immune before the virus will peter out. And hence you hear a lot about the urgency to get a vaccination that's not just for our community, but really globally. So as we've seen with the movement of COVID across borders, this is really a pandemic for the world to address. Because COVID will be in our community for the next months to years, it does speak to waves of different heights and intervals that can occur with outbreaks in our community. So this is just a schematic diagram showing the possibilities of various waves. And one is this peaks and valleys that will be occurring over a period of months. The second graph really speaks to the secondary wave or the phenomena that we've seen in previous influenzas, which means in the fall of this year, we might get more COVID in our community and sicker people than we did with the initial wave. And the third scenario is really a slow burn, where there's always a little bit of background of outbreaks in our community. Because of these waves, I got to keep moving to the next slide. And the next slide, please. No, I'm missing a slide. Because of these waves, the concept is that we need to both ramp up and ramp down our clinical activity. So this is really about a slide showing that we have to be very nimble and that when we start to reintroduce these services, we have to do it in a way that is measured and the ability to ramp down quickly if the burden of disease increases in our community. So the next steps of this is that we've been planning and we are in a position that when we get the approval that we can start to resume these paused activities. I do want to emphasize that an approval is required by the government to give us direction. I do suspect there is some confusion around the announcement yesterday by the government about restarting procedures. But in fact, our understanding today is really that we need to submit our plan to our regional table. That regional table needs to approve this plan, and it really does speak to an integrated regional approach to ramping up care. The government has asked us to hold 15% capacity in reserve for COVID patients, and therefore, and does need public health approval. And so this approval process is evolving, and we will be waiting for the approval of Ontario West to a plan that's not just ours, but St. Joseph's and all the regional hospitals. And as soon as this becomes more evident, you will certainly get more information. I am just going to spend a few minutes on the congregate care strategy. This, in fact, is Sharon Pearson's portfolio. And to be very honest, she's dealing with a crisis in one of our retirement homes in Hamilton that's in a humanitarian crisis. So is not able to give the town hall today. But to be clear, the province has asked us to play an active role as a hospital sector in assisting community congregate housing. They really have given us 3 directions that they believe is important for us to support this sector. The first is COVID. The second is really about outbreak management, which is the IPAC, and that's PPE, and it's about IPAC practice, cleaning, cohorting of patients, things that we do commonly in our hospital. And the third is workforce management, and that is really supplementing the workforce in these settings to ensure that the citizens of Hamilton are being looked after. I must say, Rob did send out a call for volunteers. Most impressively, we had approximately 150 of you come forward and put your hands up, and we have been deploying Hamilton Health Sciences employees to these work areas, and it has been to this point has been quite successful and very much appreciated by ourselves and our community. On the slide is a email address if you wish to volunteer. So I'll turn it back over to Aaron.
Okay, well, maybe, Aaron, do you want me to just jump in there?
Sorry, I was just stuck in the netherworld. I don't know what was happening. My computer wasn't responding, but I'm here. And I think maybe if we could do a quick pause for some questions, we'll do that now so that people that just heard what you just heard, you can ask questions in relation to that area of content. So just again, a housekeeping reminder, you can ask questions by raising your hand in the participants list. You can also enter questions into the chat function, please. So we'll give a couple of minutes for folks to do that now, and then I can help apply those questions to our panelists. Quiet group today. Okay, and you can also give some thought to that, and we will pause again in a little bit. We do have one comment in the chat function now. Congratulations to the 150 volunteers. Okay, well, maybe then what we'll do is we'll continue. Oh, wait, we do have one raised hand from Barb Milne. Barb, I'll unmute you now and you can go ahead with your question, please.
I am so sorry. I apologize. I didn't mean to.
Fair enough. You were just testing the function, and that's good. That's fair. Done. So I do have in our chat box then a question from Nigel Holmes. The hospital is normally well above 85% occupancy. What is it now? Dr. Stephen, maybe you could field that question for us.
Yes, so if you roll up all our beds and the number of inpatients, we're currently at 83% across the enterprise. Each individual site will have various degrees of occupancies. Some are some are up in the 90 percentile, some are in their 80s, some are below 80, but overall we're at 83%. That's where we are currently.
Thanks very much. I have our next question from Bruno Salina. What's the timeline to start procedures and elective surgeries? Again, Dr. Stephen, maybe you could unpack that a little bit. I know you touched on it to some extent. Maybe you can offer a bit more detail.
Yeah, thanks. Great question, Bruno. The answer is that we have gone through an extensive process internally. We do have a multi-phased approach. The proposal is going to Ontario West for approval. There are multiple steps for that, and that includes public health. That includes a sub-region or our old LIN table to Ontario West, which is a much larger table that Rob is sitting at, is managing that. And so to answer the question, we're waiting. There is a directive from the provincial government that has told us not to resume care. That needs to be addressed. Quite frankly, it is really, there is a criteria. There are about 9 of them that they wish to look at within that planning. One of them is we need a 30-day supply of PPE. We need to have IPAC standards. We have to have an ability to prioritize our cases. We need to have a capacity reserve of 15%. There's a few others that are in that list of a checklist that we have to submit, and Rob actually has to sign off on. There's a weekly feasibility checklist that we will be submitting to our sub-region table, and this needs to be put into context. So people are looking for, are we starting on Tuesday or Wednesday of next week? We don't actually know. We are waiting for those approvals and for that process to unfold.
And those criteria that you outlined, Wes, I know those are related to the framework that the province released. These are all of the criteria the province is looking for. I mean, Rob, maybe you could add a bit about at the regional level. I know there's a view to try and move forward in a coordinated way, given the complexity that Dr. Stephen is talking about.
Yeah, that's right, which I think is ultimately a good thing. So our hospital plan will ultimately need to be integrated into a sub-regional plan. The sub-region, when I say that, what I mean is the former LIN territory, HNHB, and then there'll be a LIN coordinated plan developed that will ultimately go up to the Ontario West level and be further integrated or stitched together with the plans from the 3 other sub-regions. So it might sound like a lot, but I think we'll be able to make it happen quite quickly in terms of the planning. But you know, whether or not we will be able to meet the thresholds that have been set out by the province that Wes has just outlined, will we have enough PPE? Will we have enough of the other critical supplies and resources, drugs, etc., to be able to actually meet those provincial thresholds is another matter. And maybe the one other thing I'll mention is that the status of the state of the virus within the community is another important consideration. So for that reason, the province has said that the medical officer of health within each community needs to sign off on these plans. They have to be comfortable that where we are on the curve as a community is appropriate for us to be ramping up these services. So I think the planning of this will be able to get done, you know, relatively quickly in the next week. Whether or not we can meet those thresholds, we are certainly going to work as hard as we can. We know that there's a lot riding on this, but some of them will be out of our control.
Thanks very much. Maybe one more question then before we proceed related to COVID specifically is how long are the measures like visiting, restrictions on visitors and screening, how much longer is that anticipated to be in place? I wonder, Dr. Stephen, if you could talk a little bit about that in the context of the pandemic and how it's still moving forth in our community, really.
Yeah, so very good questions, very difficult to answer. I would just highlight that, you know, where we started 8 or 10 weeks ago and where we are today looks dramatically different. And so these issues, I think, will be evaluated on a regular basis. I think, though, recognizing that COVID is going to be in our community for a period of time, I think, number one, the way we historically have done business is going to have to change. The way we provided care, whether it's virtual or our senses of the number of patients with respect to whether we continue to screen, I think is probably a reality in the short term, but it will depend on the burden of disease in our community. I think a lot of these things you're seeing today are probably going to be around for some period of time.
Perfect. Okay, well, in the interest of time, I know there'll be other questions, but we do want to finish promptly, so we are on time at the present moment. I'm going to move next to Bruce Squires, who's going to talk to us a little bit about redeployment. So Bruce, over to you.
Okay, thanks very much, Aaron, and good afternoon, everyone. I've had the pleasure over the last few weeks to, in addition to my normal role with the Women's and Children's Program, to be supporting Michelle Leroux, our Vice President of Human Resources, on the redeployment task force and looking at our redeployment strategy and processes. And it's given me an opportunity to kind of see it even closer, the really great work on the part of all of you that have been redeployed, and it certainly leads me on behalf of the senior team to say thank you. Really, the way we've responded to this pandemic could not have been possible without the commitment and, in so many cases, the flexibility of our teams and of our people. You've been critical, and you've played more than 15 different roles, and different in the sense of each of them being unique, but different in the fact that they're not what you're normally asked to do. And certainly I know that all of our leaders, but also your colleagues, are really, really appreciative of what you've done. A little bit about redeployment. So a pandemic, and this one in particular, means that our relative needs for certain activities and services can change quite dramatically and quite quickly. They can go up, they can go down. So we've been using redeployment to ensure that we're able to meet those increased needs, and again, particularly in critical patient care areas, and to do so in a timely manner. And it's because there are areas where activities and services were significantly reduced that we were able to do that. Otherwise, we would have had to rely on recruitment, and we all know that can take a fair amount of time. So we first used redeployment to meet urgent needs around things like screening, assessment centers, testing, so many other things. And also to do our planning, to prepare ourselves to meet forecast needs, particularly in areas like critical care, the emergency department, our wards specializing in COVID treatment. Now, with the challenges in the long-term care, retirement home, congregate care setting that have emerged, and Dr. Stevens spoke to earlier, we've now had to move to, as necessary, looking at how redeployment assists us in providing staffing to support that setting. Truthfully, to date, we have, and we hope to rely on volunteers for that process, but we also know that the situation evolves quickly. And now going forward, as we've been discussing, as we begin to increase activities and ramp up services, we know we're going to have to look at how we operate, and it's not necessarily going to look exactly the same as we previously did. So, for example, at least for a period of time, we may need to continue to operate screening. Virtual care changes are going to impact our operation. We certainly have increased testing responsibilities. Again, that's just a few. And so redeployment is, to a large extent, about bringing it all together so we can appropriately distribute our workforce in this really extraordinary time. So, you know, how it works essentially is we need to look at, do we have a place where because of the necessities of and the requirements of the pandemic, we need to feel like ramp down or reduce a particular service area, and that creates an opportunity with staffing. We need to look at where do we need increased support from our people, and where do we have cases going forward where someone had a particular service or area had ramped down but needs to begin to ramp back up, and therefore needs to pull people from the redeployment list. So really, we've got a kind of a multifaceted piece of managing and matching our workforce with the demands. And again, you know, this has relied on and really benefited from the flexibility and first and foremost, the commitment and dedication of our people. Key players, lots of key players in the who of this. Of course, number one, it's our people themselves that can be redeployed. Also involved, of course, are the managers of those individuals who will be consulted and involved when either there's an increased need or where there's a need to redeploy. Where an individual is redeployed to another area, of course, there needs to be leadership in that location. And so we coordinate this through the Central Redeployment Office. That is something that's been set up as part of our existing central staffing office. We also involve numerous other folks, including the health, safety, and wellness team, our education departments to ensure that folks are prepared, IPAC to ensure, and our supplies to ensure that there are appropriate health and safety protections. Just some of the folks that are involved. So really, as we think about kind of next steps and going forward, I have to emphasize that redeployment really is going to continue to be likely important, and it's likely to evolve as this situation unfolds. In the immediate, it's about we're needing to consider long-term care, but as Dr. Stephen has described, going forward, it's going to include adjusting for service ramp up. I can preemptively ask a question around when that will happen and when will folks know to say, kind of consistent with both Rob and Wes's answers, we don't know yet. We don't know that timing. As soon as we do, then we'll be able to make those adjustments. So with that, I'll close my session where I started, which is really to call out and thank all of the folks who've been, in this case, working in roles that weren't necessarily what you originally signed up for, but you've done that with just incredible dedication and perseverance, and it really has served us well.
Thanks very much, Bruce. I know also on this agenda item, I know Dr. Michael Stacey, we had you with us today to also talk a little bit about some of the physician workforce updates. Maybe we could go to you now, Michael. And then I know Dave McKeag is also joining us today, and he can talk a little bit about the pandemic pay. Maybe we'll do those two, and then we'll pause again for a question session. So Michael, over to you.
Yeah, thanks very much, Aaron. So really what I want to do first is just to acknowledge an enormous amount of work that was done by a number of our physician departments and services to develop their workforce plans to cope with that enormous wave of COVID patients that we thought was going to come into the organisation, and particularly internal medicine, ICU, and emergency. working together with people from medical affairs, so particularly Tanya Roglic and Erica Unelli, and supported by Helene Fagiol, who we seconded to that work. They've done an enormous amount of work to ensure that had we had that influx of patients, that we would have the medical workforce to be able to care for those patients. In addition, anaesthesia developed intubation teams, which have started already at both the General and the Juravinski to support the protected code blue teams, and they're running 24/7 at the present time. And in addition to that, family medicine and physical medicine and rehab have supported in a number of different ways. They were the groups that would have looked after patients had we had to go to a location like the Sheridan to have patients there. But physical medicine and rehab have helped with St. Peter's with some shortages they had. And family medicine has been helping with the problems that we're having in the long-term care facilities and the retirement centres. So have all acted in a way that has really been very, very supportive to the whole organisation in this crisis. I'd also just like to call out the other physicians who put their names forward for redeployment. When we had put a call out, we had almost 300 physicians volunteered to be redeployed to other areas to support, had we had this big rush of patients. And so we haven't had to utilise them, but the fact that people are prepared to do that, I think, speaks volumes for the spirit within HHS. Just like to call out 2 infectious diseases, so Dominic Mertz and his team, and supported by Kirsten Krull. They've done an enormous amount as well to look at guidelines and directions for us around PPE and protecting our staff and our patients, from the spread of the COVID-19. When looking after the patients or when doing particular procedures that are aerosol generating. So lots of work on their behalf. A quick comment that we've also brought into the organisation a cohort of physician assistants as a backup group to try and support the medical workforce. They've come in as a temporary group. We will probably be looking at some of them going forward to help with the issues we have with shortages of residents in both general surgery and internal medicine. And a couple of them are actually also currently working on the COVID ward at the General. So, again, a workforce that has been very, very useful to the organisation. And finally, just to touch on the physician compensation piece, as you may be aware, the province has put out guidelines for providing compensation for physicians who have been working on some of the teaching and learning preparation for COVID, but also doing other administrative roles, which, as you know, because physicians are not employees, they're effectively been doing on their own time, the majority of them. And so we're working through some compensation issues to understand who does qualify for that compensation. And I think the other thing that the physician group has been doing, as well as looking at preparing for that large wave of patients, now they're working with Wes and his team to work out how do we bring care back into the organisation, in a controlled manner, being mindful of all of the issues that have been touched on to date. And that includes bringing back learners and bringing research back into the organisation. We go to the next slide, please. One of the other impacts of COVID, of course, has been the travel limitations from people coming from abroad. And this is presenting yet another problem for us, in that some of the residents and fellows that support different areas of the hospital won't be able to arrive in Canada at the beginning of July. And that will have an impact on the services there on the slides particularly. There is a lot of work going on with the university. Many of these residents and fellows still wish to come. They still have their funding in place. So they're hopeful to be able to get them into the country by September to minimise any significant impact on those programs. But the programs are working on other contingency plans to try and mitigate any impact on the care of our patients. And before I finish, I would just like to make one non-COVID comment and our new impact analysis for recruiting physicians has been able to be activated in spite of the COVID crisis going on, and we hope that that will streamline the recruiting of physicians going forward. So I'll end on that note and hand back to Aaron.
Thanks. Dave, why don't we, in the interest of time, can we get you to address the topic of pandemic pay next, please?
Sure, thanks, Aaron. I wanted to give a brief update on pandemic pay, certainly a topic that I know is of great interest, as it should be. Firstly, I guess in a similar theme, I'd really like to say that HHS and me personally recognize and value the contributions of all our people. Your dedication to our community is seen every day, and it should just be applauded. Also, upfront, I would like to acknowledge that the way the pandemic pay program, which was announced on April 25th by the government, is the way it's currently defined does not necessarily include all of our staff. But what I will say is, based on the strong input from hospital members, the Ontario Hospital Association has made it very clear to government that we feel pandemic pay should apply to all hospital staff. So that's the update that I can give for today. That process still is in play. As soon as we have more information about this, including when we'll be able to implement the new pandemic pay, we'll be sure to share that as quickly as possible. That's really the update for today, Aaron. Thanks.
Great. We did have one question about the plan for our non-clinical roles in our office spaces as we think about reopening back up, and as we think about getting back to work as we follow the province's directives. Can you talk a bit about what we might be thinking about in terms of our office spaces and creating physical distancing for those workers too?
Thanks, Aaron. It's actually a great question. We've started to think about that. I don't have a ton of answers to provide yet, but understanding how many staff would be able to be in a space, how would we maintain physical distancing, I would expect that will probably take, first of all, a certain amount of time to get back to full steam, and full steam might be different. We may have more of a remote existence as we go forward. We won't be able to fill meeting rooms with people the way we used to, and the office space may need to be reconfigured to some degree. So lots of questions that we'll need to try to sort out. We certainly will make sure that as we move staff back to their workplace, that we're doing it in a way that adheres to the appropriate standards. We want everyone to be safe and yet be able to work together as effectively as possible.
Thanks, Dave. And I do have one question from our attendees, from Jen Holterman. Jen, if you want to go ahead, you can ask your question now, please. Jen, are you with us? Not yet. Okay, going to our chat line. Will the pandemic pay be retroactive, Dave?
So the pandemic pay is specified for a very specific time period. It's effective from April 24th to August 13th. So it would be retroactive to the 24th.
Gotcha. Okay, thanks. Okay, so in the interest of time, I want to keep us moving, and so we can still have a 3 p.m. sharp quit. I know that as well, we've got some more content from Rob coming up. So Rob, why don't we go over to you for that update on some of the transformation work that we're also starting to start up again.
Sure, thanks, Aaron. And I'll try to go through this reasonably quickly, but I think it's important to note that we are thinking about more than just the pandemic. In 2020, we began the year by taking bold steps to transform the way that we're providing care as an organization. And for sure, the pandemic certainly threw a big spanner in the works, and some of this work was slowed as a result. But it hasn't paused completely, and it's continuing to add value to our organization even during this time of crisis. We're shifting our focus back to some extent to this work, recognizing that it remains as important as ever for the sustainability and future of HHS. Last week, the Transformation Executive Committee, that's the steering committee overseeing the biggest projects going on in the hospital, convened for the first time since this crisis began. So happy to share a couple of updates. Even though the COVID-19 virus demanded our focus over the last few months, our managed equipment service initiative has continued to progress. That's thanks to the dedication of many involved from across our sites and programs. As you might recall, earlier this year, we announced a 15-year service agreement with Siemens Canada for the management of our diagnostic imaging fleet. That contract came into place on April 1st. This partnership represents a proactive approach to procuring and maintaining our fleet of diagnostic imaging equipment over time. There are lots of benefits to a contract of this nature, including increased equipment uptime, a fixed pricing model, so it brings predictability to the amount we're paying for diagnostic imaging, and also dedicated on-site service by Siemens. It also means we can plan ahead for equipment renewal and replacement. So just to sort of put a face on that, within 3 years, half of all of our diagnostic imaging equipment at HHS will have been replaced. And over the next 5 years, we will have replaced every piece of diagnostic imaging equipment at Hamilton Health Sciences. So last week, we started the procurement process to renew almost 129 pieces, or about 25% of this equipment across all our sites. Included in the first phase of procurement are a CT scanner at West Lincoln Memorial Hospital, a new MRI at Mumsy, as well as other equipment such as ultrasound systems, nuclear medicine cameras, and stress testing equipment across all of our sites. This is really exciting work that will benefit both healthcare providers and our patients, and we will continue to keep you apprised as that work progresses. Another major component of our transformation is our digital health plan. That's made up of a number of projects and initiatives focused on improving the digital technology landscape here at HHS for the benefit of our workforce and of course for patient care. I know many of you are wondering about the status of the hospital information renewal, hospital information system renewal project. That's one aspect of our digital health plan that's been underway for some time. Currently, our efforts, or the efforts of the project team, are focused on selecting the best option to move forward with procurement. We could do that in a number of different ways. We could join another hospital's contract, such as St. Joseph's, or we might ultimately just pursue our own. I guess what it's most simple to say, a final decision is imminent. We are expecting to bring a final recommendation to the HHS Board of Directors in June. If this work proceeds as planned, we are expecting to be able to go live with a new HIS no later of June of 2022. Until then, there is a lot we need to do to be ready for that. A major first step involves identifying HHS's HIS implementation team. I know there's a lot of acronyms there, but this will be a team initiating, and we'll have to constitute this team by seconding individuals and backfilling those positions as required. This is in addition to a series of pre-implementation projects guided by the results of our recent readiness assessment, which in and of itself was a major piece of work. So we'll have lots more to share in the coming weeks and months on the new HIS. Work on a number of other digital health plan projects is well underway, including a new advanced network and security program, upgrading Citrix to improve performance and security, implementing an advanced smartboard application which can detect early warning signs of various conditions, including sepsis. Development of a virtual care strategy, enabling patient visits using Zoom. We've done that during the pandemic, and I think it's something that we need to embrace moving forward, pandemic or not. So I know Dave and Dwayne will be happy to answer any questions you might have about any of those digital health plan projects during the Q&A. The three other big transformation initiatives, our Ontario Health Teams, our Strategic Performance Collaborative, and our Continuous Quality Improvement Management System, have been temporarily paused due to the pandemic, but we will look to resume work on those three major projects in the coming weeks and months as we settle into a new normal. So maybe I'll stop there, Aaron, and we'll see if there are any questions.
Sounds good. Thanks very much, Rob. I do have a couple of questions in the queue, some related to COVID, so might draw on other presenters. In terms of, I guess, so one related, let's start with one related to pandemic pay. Dave, perhaps you can answer, might be something that we're still waiting for the ministry to respond on, or for the province to respond on. Will Ministry of Health staff receive pandemic pay, or will Ministry of Health staff, for instance, those that might work at HHS as employees who are also part of the Ministry of Community and Social Services, or who are overseen, perhaps, thinking of those in our Ron Joyce Children's Health Center, which has services that are under the purview of the Ministry of Community and Social Services.
Thanks, Aaron. Yeah, it's a good question. I think I would answer it this way. At the moment, we are waiting for government to provide more direction, and it goes into the sort of the same bucket, I think, in terms of making sure that it provides pandemic pay to the widest possible number of staff. The intention was always to recognize frontline healthcare workers, and just want to make sure that it would do so in the best possible way. So the answer is I would hope so, but we don't have those specifics yet. And as soon as we get more, we will pass that along.
Thanks a lot. So just a reminder for all, you can answer questions. You can raise your hand in the participants section or enter into the chat function. Happy to field questions on the content around our transformation projects or anything related to COVID. I do have a question here about whether we foresee testing of staff for COVID-19 on a regular basis to be implemented as or if the situation worsens. Perhaps Dr. Stephen, I could ask you to weigh in on that question.
I think that's a great question. I'm not sure that I can truly answer it today. As we all know, part of pandemic management is widespread testing. There has been a focus on healthcare workers. Whether or not we get to asymptomatic screening of healthcare workers on a frequent basis is a bit of a jump from where we are today. So I am not envisioning that will be something that we will see in the short term. However, if the burden of disease increases in the community, that's obviously something we would be looking at and relying on our experts, Dr. Mertz and team, to give us real evidence-based decisions. They've been an amazing group of Kirsten Kroll and Dominic giving us advice as experts of when and what we should do with respect to testing.
Great. I do have two questions in the chat forum about our elevators and about the prospect of physical distancing in our elevators. I guess the question being, will we continue to limit or holding the limit of people in the elevators to 4 people at a time? And if that's our aspiration, how are we going to ensure that that happens? Perhaps maybe Dave, I could go to you first, but of course others are welcome to jump in too.
Thanks, Aaron. Actually, all of the initiatives and all of the protocols that we might want to be able to follow with respect to physical distancing and making sure that all of our staff and ultimately when we move back into that space, visitors, et cetera, are safe. All of our sites, the physical space, we are going to be assessing. It's under active consideration. How do we do that? How do we do that and still provide care and allow the staff to be able to be effective? So the short answer is we do need to consider it. And I don't have all those specifics as yet today. Work is underway with the group and some discussions active into next week. So hopefully we'll be able to provide more on that. I will say that the approach is always to follow as best we can within the physical space that we have all the safety measures that are indicated and appropriate.
Thanks very much. I do have a question here. I know we've been talking a lot in the public space about whether or not we'll be able to achieve immunity from COVID-19. There is a question about whether or not there is an approved antibody test yet for COVID. I know, Dr. Stacey, you and I have talked about that in the past. Maybe you could offer some perspective on what the research community is working on to try and be able to test for antibodies for COVID-19.
Yeah, thanks, Aaron. So there is a lot of work going on at the moment to try and develop an antibody test. And I think you've probably seen in some of the media releases, there is a plan nationally to look at doing a screening of the population for antibody testing. So in other words, to understand, what is the extent of the disease within the population or people who've had the disease. I think there's still a lot of work going on at the moment trying to understand exactly which antibodies to test for and what they actually mean, because we're still even understanding the natural history of the human response to this virus. So for sure, a lot of work going on. I don't think there's been one that's been at this stage identified to do that sort of screening, but they're driving towards that.
Thanks for that answer. One question here from our chat forum: why is it not possible for staff to exit buildings using the main entrance now that we've implemented universal masking? Maybe, I see Kirsten, you've joined us now. I know you've been intimately involved in the work for our PPE and our masking. Is it something that maybe you could offer some perspective on as to how we're using our entrances and exits now that we have this universal masking policy in place?
Thanks, Aaron. So it's primarily to keep people kind of streamed in a separate way. And of course, people are being screened from the public in our main entrances, and our employees are going through the alternative routes. So we're trying to really keep those streams of activity separate and really back to the social distancing. These sort of things we will review on an ongoing basis, but it is what it is at this point in time. But of course, things may change as time unfolds, but that's kind of the rationale behind that at this point in time.
Wonderful. I know there are still questions coming in, but I do want us to close on time. And I do know that we also wanted to have an opportunity for some celebrations for the organization. I know maybe Kirsten, you wanted to, it's National Nursing Week. Well, international is the year of the nurse and midwife. So maybe it could get you to offer a bit of a shout out first for that particular.
Yeah, and I have my shirt on. I'm a nurse, and I'm so proud to be a nurse. So congratulations to our over 4,400 nurses of HHS. It is absolutely the year of the nurse and the midwife, really celebrating the 200th anniversary of Florence Nightingale, who of course, so timely at this point, although who would have ever guessed, but Florence Nightingale was certainly pushing for issues around infection control, hygiene, and recovery of patients with wartime soldiers. So, very critical conditions at that point, and many of those principles live on today. So she really has helped to think about modernizing nursing way back when. Of course, the Canadian Nursing Association has a slogan this year called "The Voice to Lead: Nursing the World to Health," which I think is a perfect slogan for Hamilton Health Sciences, as our nurses are in so many different corners of this organization, looking after our smallest of infants to our most senior people, and really trying to have a lot of different influence on not only the acute care of patients, but many of the issues that people will be dealing with in their lives, and really trying to improve that quality of life. So it is a time, certainly the National Nursing Weeks are times for us to think about not only gratitude of our staff and the extra mile that they go through every day, and thinking about the tough work that goes on, not only in the care and the heavy care, the physical care of patients, but the emotional labor, as Andrea Frolick often refers to it, which is so poignant. It is a very tough job from the point of view of the patient-facing and family-facing challenges every day. So your compassion is exemplary. The adaptation that many people around the panel have talked about today is really what is important in this profession, and really using knowledge and skills on a day in and day out basis and keeping in touch and up to date with those skills and abilities. I really appreciate our nurses. I wish I could write a note to each and every one of you, but impossible. But it is about, exemplary ways that people hang together as teams, do exceptional team problem solving, and it's really great to see nurses oftentimes involved with so many CQI undertakings. The virtual care models that are being experimented with are exceptional as well, and really are going to change the face around how we can do care of patients. So I encourage you to take a close look at the progress that we're making as an organization. A number of you also went through critical care training at this over the last 2 to 3 months, again in preparation for any surges that might come about. Of course, that's quite a challenge for many people, but people have stepped up and really kept together as a team to do that. We've had so many practice changes, not only now, but if I think pre-COVID, and sometimes a bit foggy for us right now, but if you think about some really key milestones that we've made progress on in the organization, just some examples is serious illness conversation work that's going on in a number of different areas, medicine and critical care. We've made some huge gains in central line infection reduction, and along with that, sepsis improvements as well. Urinary catheter use substantially down, really makes a difference in patient outcomes and so on. So be very proud of so many things that we've accomplished, not only in the last 2 to 3 months, which are very vivid for us, of course, but amazing work that goes into our organization and into our community day in and day out. So I thank you for that. Take a moment to think about also education. I mean, this is about educating our public about what is nursing all about. We should never stop having those messages out around the importance of the roles, and again, how we do that alongside other team members. Maybe take a moment as the week starts to wrap up about thinking of those staff that you interact with upstream or downstream. Primary care sector is a great one, as nurse practitioners, as an example, are a big part of that system, or long-term care, which we've talked about as well today, home and community care, but even departments that kind of hand patients over from department to department. So we all have our own nucleus of team members that we have great gratitude for, and thank them for that work, but also think about those other people who have impact on your day in and day life in the care of patients. So I thank you from my heart. I'm so proud to be at HHS, and woohoo to our 4,400 nurses, and of course all the other healthcare workers that we work alongside with. So congratulations.
Thanks for that. I know we did have some images that we were going to show related to our COVID-19 response, some nice things to think about and reflect on. Maybe we'll post those to the hub as an alternative and people can view them there. I want to keep us to a firm stop at 3 o'clock. So maybe, Rob, over to you to offer some closing remarks, and we'll wrap up until next time.
Thanks very much, Aaron, and thanks all for your participation today. I'll add my thanks to all of our nurses in celebration of Nurses Week. Normally, I think this would be the week that we'd be getting together and having a dinner in Stony Creek in celebration of some of the best of our best nurses. So I'm very sorry we're missing that. But thank you for all that you're doing, and thanks to, of course, to everybody. Healthcare is a team sport. So we all have to come together to make this work for our patients. And I couldn't be any prouder of all of the work that's been done by the teams here at Hamilton Health Sciences during the course of this pandemic. People have really stepped up for our community. So thank you very much. I know our community is grateful, and I'm very grateful. We didn't get to every single question today, but if you had a question that wasn't answered, you can submit that to hhsnews@hhsc.ca, and we'll make sure that we respond. Our next town hall is scheduled for 2 weeks from now. If there are specific topics you'd like us to address, please send a note to that same address, hhsnews@hhsc.ca. And we'll do our best to shape the next town hall to reflect the various themes that arise from that input. Once again, thanks to everybody, and stay safe. And for those of you who are going to get, I hope some of you are going to get some time off this weekend. I think at least Saturday looks like it'll be nice. So I hope everybody gets a bit of time to spend with friends, if not friends, with family over the course of the next few days, although I know the social distancing limits the extent to which that can happen, but at least the family members living in your households. Anyway, thanks so much, everybody. Cheers.